Good afternoon. My name is Dr. Clement Nuka. I'll be continuing my heart story. I have quite a number of questions that need to be asked by our healthcare workers to a patient who comes in with a chest pain, or perhaps a chest discomfort. This time, coming to the hospital with a chest pain addressed or with minimal effort. This is an indication of the immensity of the problem. This is addressed. In the past, we said something about pain on exertion, pain on, I can say, maximal exertion. That was understandable. Then this brings me back to my equation, the demand and supply equation. We said the demand, if the demand equals to supply, then that's perfect. The picture is rosy. As soon as there's an imbalance, we get worried. Is it the demand side that is the problem? We can do something about the demand. We can reduce the demand so that the demand of oxygen, so that at least the supply should be able to help the situation because the demand has been reduced. We do this in quite a number of ways. We reduce the work of the heart. We reduce the blood pressure, for instance, so that there's no constriction. Remember, the blood pressure, its towering feature is constriction, and that increases the work of the heart. And we're talking about a heart that's failing. A heart that's failing has got to be helped by making sure that you reduce its workload. But now, today, I want us to say something about minimal exertion or minimal or addressed. The patient is addressed, but the patient has pain. The patient wakes up at night with this terrible pain, chest pain. These are alarm bells ringing. These are alarm bells ringing. You know, before an earthquake, there's always a tremor. This is a tremor. And if the tremor is not at, you will ask me this question. You will say, why does a mild angina, a mild chest pain, why does it change suddenly and become an unstable angina? Why does that happen? The answer is the supply has decreased. Why is the supply decreasing? The supplies, maybe, I don't know, maybe there's a clot formation. If there's a clot formation, it means obstructing the flow of blood. So this has got to be treated. This has got to be treated. And this is a big problem. People, first of all, the patient has got to be admitted. No patient with a chest pain at minimal effort or minimal exertion should be sent home to say that, no, you're okay, go home. No patient who is patient, like I say, minimal effort or no effort at all, minimal exertion or no exertion at all. A patient at rest, no patient at rest, no patient at rest with a chest pain or a chest discomfort should be sent home. Because those are alarm bells ringing. That's an unstable angina. Why does it change? It changes because the supply is decreasing. That's the main thing. There's a disturbance of the equation. That is the demand and the supply equation. You're clear about that. There's a disturbance of the equation. And if there's a disturbance of the what has actually happened? How can you help? The patient needs a drip. And the patient has got to get heparin through a drip and has got to get orally, the patient has got to get aspirin. All these are to thin the blood, to make sure that the blood is thinned. If there was a thrombus, let it dissolve, let it dissolve, let it dissolve. Let's thin the blood. Let's thin the blood. How are we going to thin the blood? Intravenous heparin and oral aspirin. These patients, they normally improve. You know that? They normally do. They are normally saved from heart attack. They are normally saved. Remember, heart attack we regard it as an earthquake. Earthquake is very destructive. Very, very destructive. But an earthquake, there's a prerequisite. There is something that precedes an earthquake, and that's a tremor. We're treating the tremor. The tremor is your unstable angina. Unstable angina, there's something that we need never to overlook. We have been drawing a very good picture, and there's nothing wrong with the picture that we've been drawing. That of saying it's first of all a stable angina, and that is followed by an unstable angina, and that is followed by a myocardial infarction or a heart attack. There's nothing wrong with that. That's a very good logic, because what you have in mind is the growth of the atherosclerotic plaque. So it grows with time. It grows with time. So it has grown, and it has changed. It has changed a stable angina to become an unstable angina. It has changed an unstable angina to become a myocardial infarction. This is, of course, without any intervention. If there's intervention, this can be stopped. If there's you can intervene even from between a stable angina and an unstable angina. You can intervene. You can intervene between an unstable angina and a myocardial infarction or a heart attack. You can do that. But the point I want us to take home today is this one. You can get, for the first time, a patient with these patients that I'm describing, those are symptomatic patients. For instance, a stable angina, that's very symptomatic because the patient is going to complain of pain, chest pain. You know, and you call it an angina pectoris. That's a symptom. The patient is going to complain. Now, the patient has not been complaining at all. And suddenly, the patient has this savage chest pain, this bad chest pain. That patient must be taken to hospital immediately. You mustn't say, oh, no, but this patient is complaining for the first time with this pain. And so what it can be a ringing bell. It can be an alarm ringing bell that is saying unstable angina. In other words, this is a tremor which precedes a what? An earthquake. An earthquake is your myocardial infarction or your heart attack. So this, and that's very destructive. No one wants to get there. So this is something that we have to learn today. But now, what type of questions must a healthcare worker ask? What type of questions must a healthcare? If as a health worker you don't ask anything about risk factors, you don't ask anything about, say, for instance, you say to a patient, any history of smoking? Do you smoke at all? Or have you smoked before? You need to have that history, because you know that that's a risk factor for an MI. That's a risk factor for a chest pain, any chest pain. Well, no, not. I'm talking about a pain from the heart, an angina. You need to ask any heart problems at home, any heart problems at home, maybe your mother, father, brother. Then the patient is going to come, oh no, my brother had some thrombosis of some kind, and my mother had, people will come with history. People will tell you exactly what happened at home. Some of them, they lose their siblings because of a heart problem. So it's important. It's important that you ask that question. Because if you don't ask that question and you start discharging the patient and say, without asking questions like that, you start discharging a patient with a chest pain when the chest pain is actually an unstable angina. That's one of the worst things that a health worker can do. So we want to make sure that we ask the right questions. You are not going to let a patient go away because what we normally do, we give them these nitrates under the tongue. We give them the nitrate under the tongue, and then the patient says, oh, I'm fine, I'm okay. Can I go home? And all that. And then really the patient is okay. The temptation is very high that you say, you release the patient to go. You actually do a chest x-ray and you notice that the chest x-ray is normal. And you do an ECG, you notice that the ECG is normal. Then you say, you're tempted as a healthcare worker to say this patient can go home. This patient mustn't go home. This patient is the type of patient who really needs to be investigated because you don't know what has happened. How has that heart been affected by that chest pain? Why did the patient experience such a bad chest pain? So this is crucially important. to say that I am not going to allow this patient to go home because I don't know what's happening. I need to investigate this patient. And a lot of investigations can be done. You know, the medical department, they know exactly what to do. The cardiology department, they know exactly what to do with a patient with a chest pain. So this is something crucially important. What is tempting is a chest x-ray that's normal. What is tempting is an ECG that's normal. No, you're not going to base your assessment on that and say the patient qualifies to go home. A patient with a chest pain at rest doesn't qualify to go home. Chest pain at rest, you know, there's this, I said, the reason why the patient has changed from a mild, or perhaps the patient from a mild chest pain, or from a mild, shall I say, angina pectoris, and to become an unstable angina pectoris. We said we don't know what that's what needs investigation. We said our explanation for that, we said it's because of a decreased supply. Decreased blood supply. But what could cause that decreased blood supply? That's the main thing you need to answer. And you're not going to answer that by discharging the patient. You're going to answer that by investigating the patient. What could have been? You know, there's something. If you look at the artery has got that internal area known as the intima. And the intima has a muscular coat. And if the muscular coat were to have a spasm, immediate contraction like that, it's going to decrease the diameter of the lumen. And if it decreases the diameter of the lumen, it's going to obstruct blood flow. And that can be the reason why the patient has an unstable angina, has got a pain first of all. Patient who didn't have a pain before at all, have because of that muscular coat that has gone into a spasm, And that spasm now results in obstruction of the blood flow, to the distal portions of the body. Obstruction of the blood flow. In fact, we made it very clear that we don't want obstruction of blood flow. We said something about the fuel pipes of the heart. Oh, I want to mention that again and again. The fuel pipes of the heart. We said there are two on the left. We said it's the left anterior descending artery. We said the left circumflex, the one that wraps around the heart. We said on the right we have a right coronary artery. Those, we can't talk of the intima or the muscular coat having a spasm in those. We don't want that. And we said these are vulnerable. They can have that spasm. And that spasm is going to cause what? A decrease in the supply of blood to what? To the myocardium. And this is unfortunate. We don't want that. So We want to make sure that this, and we can relax that. We can relax that muscle. We give drugs like the drugs that we are giving, for instance, heparin to make sure that the blood is thinned. We can give drugs which will be relaxing that muscular spasm. Muscular spasm. Of course, if you talk to the to the not the the cardiologist, they are masters of that. You know, you must remember, I'm talking in my capacity as an OPD doctor, an outpatients department doctor. In other words, a primary health care doctor, just a clinician running a clinic, just a clinician. And I don't want to take it upon myself to actually treat heart patients. What I want to do is to refer them, but with appropriate knowledge, knowing that this has got this one is good. That will be a very good conversation with the cardiologist, a very good conversation with the physicians. Those people, they are the masters. They are the ones to decide what are we going to do, how are we going to relax that muscle, that muscular coat. If you suggest that to them, hey man, they'll have good respect for you because you've made an effort to understand this that muscular coat. If it goes into a spasm and I want it relaxed, doctor, what is it that we can give? They are the ones to decide on that. But you know that it has got to be relaxed. You know that. That's very good. That's very good of you to know that it has got to be relaxed. And at the same time, if you've asked the good questions, like the diabetes history, as a respect, the smoking history, familial problems with heart and all that, you've asked that. Man, when you are giving a report to the cardiologist, you're giving a report to the physician can only smile because this doctor who's talking to him is he looks knowledgeable. He's asking all the relevant questions that I need to know, right? Whose answers I need to know, right? So this what we need to understand is that we are going to prevent a catastrophe like an earthquake. Our earthquake is your myocardial infarction, is your heart attack. We are going to do everything to make sure that we prevent that. We are going to give our heparin. We're going to give our heparin intravenously. We're going to give our thinning drug, that is aspirin. We're going to make sure that the blood is thinned so that there is no problem going forward, right? We don't want to be dealing with thrombosis. A thrombus, no. I would like to dissolve that thrombus. I would like to make sure that everything, and only if I give heparin intravenously. And of course, it's not going to be given by you. In OPD, you don't do that at all. But if you make a suggestion to your cardiologist, or you make a suggestion to your physician, your physician is going to be so excited because that is the way forward, right? So basically, these are the things I would like us to look at to make sure that the next time I'll be talking to you about the other complication of heart attack. Today, I was just rounding up just to make sure that we don't get to a catastrophic event that is a myocardial infarction or a heart attack. Let's rather stop at the angina stage. And let's not even get to the unstable angina where the frequency of the angina, of the pain is high. let's, I would like also to just to make sure that no one overlooks a patient who presents for the first time, presents with a terrible heart chest pain for the first time, and say, no, the patients that I will take to hospital are only patients who have a history of a chest pain, who had a mild, angina, and now developing to it. No. This patient, remember, because of inactivity, there are patients who sit down, who don't do any active work. So those patients are never under, there's no exertion. So because there's no exertion, these patients, remember we said exertion, when there's adrenaline will cause, when there's exertion, there will be adrenaline deposited. When the liberation of adrenaline is going to cause constriction. It's going to cause a constriction. It's going to cause an increase in the work of the heart. But these patients are inactive, so there's no activity. There's no exertion. So there's no liberation of adrenaline to let us know that, so that the patient becomes symptomatic. This patient is ever sitting down, that patient will have one attack, and that attack will cost. So that is why, if that attack comes, that patient, I'm talking about the angina pectoris, the pain, that severe pain, that patient must be taken straight to hospital. And we must not say, no, I need to have a stable angina, and then which builds up to an unstable angina. No. This patient can present today with an unstable angina, and he's got to be taken to hospital for admission. Thank you very much for listening to me. The next time I talk to you, I'll be talking about another complication of an MI. Thank you very much.